The brain matters: traumatic brain injury and intracranial pressure. Pathophysiology for the brain. A concussion is a sudden blow or a jarring that shakes the brain in the skull. Cerebral contusion is a bruise to the brain that occurs with swelling. A coup and contre-coup injury can cause a cerebral contusion. The coup is the site of the injury, and the contre-coup is the opposite side of the injury. For example, if the coup is located in the right temporal area where the injury is, then the contre-coup would be on the opposite side in the left temporal area. Epidural hematoma is blood between the skull and the dura. The middle meningeal artery is the most common due to location at the temporal site. A fracture to the temporal bone can tear the middle meningeal artery. An epidural hematoma is a medical emergency. The patient is awake, soon followed by unconsciousness and unresponsiveness. Subdural hematoma is venous bleeding between the dura and the arachnoid. Intracerebral hematoma is when there is blood in the brain tissue. The bleeding into the tissue can cause edema in the brain. Diffuse axonal injury. This is known as a shearing that tears the white matter of the brain, and this is usually associated with a poor prognosis. The brain. It's important to know that there are three components to the brain: cerebral spinal fluid, blood, and brain tissue. Primary injury is the time of impact and usually from trauma. Secondary injury occurs after the primary injury, and this can include hypoxia, ischemia, hypotension, edema, or increased intracranial pressure. This is why nursing management is so important. Understanding the terminology for brain injury is needed. Cerebral blood flow is the amount of blood that goes through the brain. The brain requires constant oxygen and glucose in order to function, and cerebral blood flow is affected by oxygen and carbon dioxide. Carbon dioxide increases vasodilation and increases cerebral blood flow. A decrease in carbon dioxide increases resistance and decreases cerebral blood flow. Any pathological state that affects homeostasis of the body affects cerebral blood flow. Autoregulation is basically what the name implies. It is an automatic adjustment of blood flow to the brain. In essence, the diameter of the cerebral blood vessels constrict or dilate in order to maintain cerebral blood flow and cerebral perfusion pressure. Autoregulation functions between a mean arterial pressure of 70 to 150 millimeters of mercury. Outside of these boundaries can cause cerebral ischemia. Cushing's triad is a systolic, hypertension, widening pulse pressure, bradycardia, bounding pulse, and changes in respirations. Cerebral perfusion pressure is the pressure needed to keep blood flow to the brain. When the cerebral perfusion pressure decreases, so will the cerebral blood flow. A low cerebral perfusion pressure can lead to ischemia and further secondary cellular injuries. The use of fluids and pressors to aggressively increase the cerebral perfusion pressure can result in pulmonary complications. The Brain Trauma Foundation has listed 50 to 70 millimeters of mercury as the range in which 60 millimeters of mercury is considered optimal perfusion. An increased intracranial pressure happens whenever there is an increase either in cerebral spinal fluid, blood, or brain tissue. The loss or impairment of autoregulation, systemic hypertension, increased carbon dioxide can lead to cerebral edema. The displacement of brain tissue leads to more tissue hypoxia, acidosis, and eventually tissue death. Unrelieved pressure can lead to a brain herniation. Clinical signs for brain injury. The patient with traumatic brain injury can have a change in level of consciousness that can range from feeling confused to a coma. Restlessness and agitation might be caused by hypoxia. Signs of a basilar skull fracture could be noted with battle signs and raccoon eyes. Cerebral spinal fluid that is leaking from the ear could be from a posterior fossa skull fracture. Leaking cerebral spinal fluid from the nose could be an anterior fossa skull fracture. Normal saline or lactated ringer should be the standard resuscitation fluid until further studies show a clear benefit from other therapies. Normovolemia must be maintained and episodes of hypotension avoided. As always, establishing and maintaining an airway is the top priority. Deliver supplemental oxygen using a bag valve mask device until a definitive airway is placed. Ensure that the patient has 2 large bore IVs and that they are intact and patent. If volume resuscitation becomes necessary, use warmed isotonic saline. It is the fluid of choice for head injuries because it won't aggravate cerebral edema. Isotonic means equal. It does not cause a fluid shift because the fluid is not in the cell and it's not out of the cell. Everything is where it should be and volume is increased. Fluids given to trauma patients, especially those to be given in large volume, should be placed on a fluid warmer to prevent hypothermia. Hypotonic fluids cause the fluid to shift into the cell. Free water, as in a dextrose solution, should not be administered. This will decrease plasma osmolality and so increase the water content of brain tissue, the blood-brain barrier acting as a semi-permeable membrane. Elevated blood sugar levels are associated with the worsening of neurologic injury after episodes of global cerebral ischemia. Ischemic brain metabolizes glucose to lactic acid, lowering tissue pH and potentially exacerbating ischemic injury. When fluid goes into the cell, the patient is at risk for an elevated intracranial pressure. The cells in the head are forced to swell. When fluids are being shifted into the cell, it is coming out of the cardiovascular system, and this causes a risk for cardiovascular collapse because the movement of fluid is going where it is not supposed to be. Hypertonic causes fluid shift out of the cells. When a cell is placed in a hypertonic solution, the water diffuses, moves out of the cell, and causes the cell to shrivel. Airway is a priority. The PaO2 maintenance at 100 millimeters of mercury or greater. Blood gas analysis guides the oxygen therapy. They may require mechanical ventilator. Hyperventilation therapy was the mainstay treatment, but now found that aggressive hyperventilation increases the risk of focal cerebral ischemia and adversely affects the outcome. Intubation and mechanical ventilation are necessary if the patient can't maintain or protect their airway because their level of consciousness is decreased. Intubation and ventilation are also necessary if the patient is in danger of losing their airway because of swelling from a neck or pharyngeal injury, or if they have expected to deteriorate neurologically. Vital signs. The nurses must monitor for changes in vital signs such as bradycardia and tachycardia, varying breathing patterns, hypertension, or a widening pulse pressure. Cushing's triad, which is bradycardia, increased systolic pressure, and increased pulse pressure, could indicate brainstem ischemia leading to cerebral herniation. Although hyperventilation can rapidly lower ICP in some patients, it can also result in markedly reduced cerebral blood flow. Therefore, limiting its use may help improve neurological recovery. Neuro. The patient with a traumatic brain injury has or is at high risk for increased ICP. By monitoring for symptoms of increased ICP, it enables the nurse to evaluate the ability to integrate commands with conscious and involuntary movement. GIGU. Monitoring bladder distension and bowel constipation, and administer stool softeners and use the Crede technique, which is applying pressure to the suprapubic region with the fingers on one or both hands to empty the bladder. If the Crede method is not effective, evaluate the pros and cons of urinary catheterization if the bladder remains distended. Constipation and bladder distension increase intrathoracic or interabdominal pressure and place the patient at risk for impaired venous drainage from the brain. Nutrition. After a moderate or severe head injury, patients use more energy as their body's metabolism is working at a greater rate. This increases the body's nutritional requirements, which may lead to malnutrition and other complications. Total parenteral nutrition provides an alternative to conventional enteral feeding. Enteral feeds with gastrostomy tube are preferred if the patient is unable to take enough food by mouth without aspirating. These patients need protein, calories, zinc, and vitamin C, especially for wound healing. Musculoskeletal. The goal is to reduce spasticity. Encourage range of motion exercises in the absence of increased ICP. Passive range of motion does not strengthen muscles, but does help maintain joint flexibility and help prevent foot drop. Drug therapy. Antibiotics. If there is an infection, they will most likely get a broad spectrum first. A culture will help determine the best antibiotic to fight the infection. Anticonvulsant. Anti-seizure meds to prevent seizures should begin in the first 7 days. Anytime there is blood in the brain, the patient is at risk for seizures. Corticosteroids can be used to treat vasogenic edema around tumors and abscesses. Steroids are used to decrease inflammation and improve neuronal function by improving cerebral blood flow and autoregulation. The caution with using corticosteroids is the risk for increased blood sugar and possibility of infections. In addition, GI bleeding is a risk factor. If a corticosteroid is used, then an antacid, a histamine receptor blocker, or a proton pump inhibitor should be given. Diuretic. Furosemide with mannitol helps to prevent rebound increased ICP. Mannitol is given if ICP is greater than 20 millimeters of mercury, but it is important to monitor electrolytes, and it is contraindicated if renal disease is present and elevated serum osmolality. Insulin therapy. To prevent elevated serum glucose levels, patients with controlled glucose levels require less vasopressors to achieve a CPP between 50 to 70 millimeters of mercury. Neuromuscular blocker. If a neuromuscular blocker is used, then sedatives must be given. A neuromuscular blocker would be given to decrease cerebral metabolic rate. Norepinephrine is used to keep the CPP between 50 and 70 millimeters of mercury. It produces vasoconstriction while reducing the heart rate. Low-dose dopamine can cause vasodilation, while higher doses can result in vasoconstriction and increased heart rate. Pain medication and sedation both help to prevent increased ICP because agitation can increase cerebral metabolic rate for oxygen consumption. Practice recommendations from the American Association of Neuroscience Nurses Clinical Practice Guideline Series. The original guidelines for the management of severe brain injury recommend treatment be initiated for ICPs greater than 20 millimeters of mercury. Uncontrolled intracranial hypertension results in an absence of cerebral perfusion and ultimately in brain death. Draining the cerebral spinal fluid from the ventricle reduces intracranial pressure. Sedation decreases cerebral metabolic rate for oxygen consumption. The use of propofol can help decrease the intracranial pressure. Use less neuromuscular blockers, benzodiazepines, barbiturates, and less cerebral spinal fluid drainage was needed. By increasing the head of the bed, it promotes venous return and cerebral spinal fluid drainage from the head. As the nurse, be vigilant and check that the cervical collar does not diminish the venous outflow. Increased pain and discomfort from the cervical collar can increase intracranial pressure, and studies have shown that keeping a blood sugar lower than 110 millimeters can achieve the same cerebral perfusion pressure with less vasopressors. An increased temperature can increase the ICP due to vasodilation. Hypothermia can cause ischemia due to vasoconstriction, so maintaining a normal temperature may prevent an increase in ICP.